Opposition?
Have enough?
Yeah.
Mr. Chair, members, Bryce Doherty here on behalf of the California Society of Anesthesiologists. As Dr. Pand would tell you, we are the physicians that keep you alive while the other physician fixes you. Arguably a very important piece of the healthcare puzzle. We're in the unenviable position of opposing the bill today, even with the mock-up amendments that were distributed to us late this morning. I want to start by saying I think all of us here at the table agree with the intent of the bill, which is patients should not be subjected to surprise bills. I think there's a difference of opinion whether or not this bill passes and signed into law by the governor, that it will in fact take the patient out of the middle, maybe from the financial aspects of out-of-network care, but certainly not for access to services and the adequacy of networks that health plans are required to have. We've been engaged and committed to the stakeholder process with the author and other stakeholders for the last 3 months. I think if you look at the vote count and the analysis, those votes were conditioned on the fact that we would have a fully cooked piece of legislation at every step of the way that included some form of fair interim payment and a fair and robust IDRP process on the back end. The bill was amended on July 7th to prescribe some of the principles in that IDRP process. We've spoken with all of you as to the fact of where we find flaws in that makeup of those provisions. Now we're punting those, some of the most important provisions of the bill, to the departments. We're not sure if those are substantive spot amendments or if that's how the bill is going to move forward. If and when the bill gets out of committee today, we are still going to continue to commit to the stakeholder process. But I think it's important for everybody to understand that there is no such thing as an average contracted rate. There is no such thing as a non-contracted rate. Those are falsehoods. Physicians usually charge a usual and customary rate for their services, which is a community standard for the particular area by which they practice. They agree to a contract with a health plan, and they agree to take substantial discounts off of those usual and customary fees in exchange for the understanding that they are going to get increased patient volume of referrals from that plan. This bill will disincentivize the health plan and the physician to come together to sign a contract, because they are going to be reimbursed only what they would get as if they were an in-network provider, without the benefit of having a contract with that plan and receiving increased volume for that decreased discount. For all those reasons, we're unfortunately opposed to the bill today, but do want to recognize not only your work, Senator Hernandez, but Mr. Bonta's work and Herculean efforts to increase access to affordable care. But unfortunately, we don't think this bill gets us there. Thank you.
Thank you. We have about 2.5 minutes left.
Thank you, Chair and members. Stuart Thomas on behalf of the California Medical Association. First, like to thank the author and the sponsor. There have been a lot of negotiations, a lot of stakeholder meetings, and a lot of work that's gone on behind the bill. So we'd just like to thank you for that. We are going to oppose the less amended in our first read of the bill that we again received this morning. I will say it's an improvement definitely on the bill in print. We do still have some concerns. First, pegging the default rate at the contracted rate. We do think this provides an incentive in law for plans to force those contract negotiations down, because those negotiations will have a direct effect on what they have to pay out-of-network providers who are not a parties to that contract and not a party to those negotiations. Secondly, on the IDRP, I think we would like to fill in some of the details. I think there is some discomfort leaving all those decisions to the regulators at such time. And I do think in order to have an effective IDRP process that does actually solve rate disputes between the provider and the plan. It needs to be simple, it needs to be efficient, and it needs to be cost effective. And so we would like to see kind of some of the details around exactly what that IDRP process might look like. I know we have another stakeholder meeting tomorrow at 8 a.m. We plan on being there, and we plan continuing discussions going forward. But at this point, we're still opposed to less amended. We don't have authority to remove that until the bill is in print. And so that's our position going forward.
Thank you. Anyone else?
Mr. Chair and members, Bob Ackerman on behalf of 2 hospital-based specialties, radiology and pathology, echo all the comments from the previous speakers. Those 2 hospital-based specialties are much like ER. They are contracted with the hospital. They're providing 24/7 coverage. They take all patients, not knowing their status is insured or not. So to remove this option to not contract basically is to basically have them accept the contracted rate, whatever that happens to be, and to go through what could be an extensive and lengthy process in terms of appeal and the IDRP. So we think the answer is at a fair payment amount that fairly compensates the physician for their responsibilities and doesn't make this so one-sided in terms of the negotiation process or absence thereof. So we are opposed unless amended.
Thank you. Anyone else?
Mr. Chair and members, Tim Shannon representing the California Orthopedic Association. Also want to thank the author for trying to solve this knotty problem. Your analysis mentions a whole host of bills that have been introduced over the years to try and address it, and we still really haven't come to grips with the problem. Don't know exactly what's in the bill, just saw the mock-up about an hour ago. We will continue to work with the other stakeholders and the author. Thank you.
Elena Lopez-Guessman on behalf of the California chapter of the American College of Emergency Physicians. I really appreciate the author trying to solve this problem, as Tim mentioned, that has been looming for a long time. The patient pays the premium to the insurer and expects that they're going to get the care that they have and not get a bill. And we want to make sure that that doesn't happen. We've been proud to sponsor legislation on this topic in the past, but we really feel like a solution has to protect both the patient from the unknown bill, as well as make sure that they have access to the physicians that are there. And so we want to thank the author and the chair and the staff for recognizing that the solution that's in the mock-up that we saw this morning would not be an adequate solution to protecting the emergency care safety net, and therefore exempting those services from the most recent proposed solution. So we appreciate that. Thank you.
Thank you. We can just state your name and position. Time is already elapsed.
Sure. Thank you, Mr. Chair. Tim Madden, representing the California Society of Plastic Surgeons and the California chapter of the American College of Cardiology. We have an opposed position on the bill in print. We're reviewing the mock-up at this time.
Thank you.
Thank you.
Anyone else?
Seth Bramble here on behalf of the California Teachers Association. Sorry to be out of order. We're in strong support.
Thank you very much. Thank you. Any questions? Senator Nielsen.
Let me ask the opposition here to focus in on something. It seems to me like one of the problems is, how static this rate can be, the factors that must be considered. Would it not be helpful if the Department of Managed Care and Department of Insurance had to regularly review these criteria again, these items, and have to be updated some way so it wasn't so static? Wouldn't that be helpful to you?
Senator Nielsen, the way in which the bill is constructed, it speaks to an average contract and rate.
No, so I'm trying to get around that average. That's what's bothering me.
And that is, unfortunately, in the bill speaks to this, that is confidential proprietary information that isn't available to the public. It's not a static, it's not a transparent rate. And your contracted rate may be different than Mr. Parra's contracted rate, which might be different than Ms. Wynn's contracted rate. So that is kind of the problem. We actually proposed solutions that was adopted in New York, which does establish a very transparent public database by which we could peg something with regards to the interim rate. The problem with an average contracted rate is Blue Shield, Health Net, Aetna can all get together in a room and they can say, what's your average contracted rate in the East Bay? Or
Well, first of all, they can't do that because it's antitrust and it's illegal. So let's not use that as an example.
well, the same thing for the physician. Same thing for the physicians.
Same thing with the physician. So we're not going to go down there.
So the physicians don't know what an average contracted rate is either.
Well, assuming that that's not a good answer, it appears that there needs to be some more work done here on both sides of the issue, as far as I'm concerned. And Mr. Chairman, you know how fastidious I am about process, and it would seem like this has come upon everybody with just a few hours to even look at it. Am I correct? And honest, guys, this is a major issue. This is not the way the government ought to work. This is not the way the legislature ought to work. We do it too much. I would recommend to make it a 2-year bill.
So I don't disagree that it's a major issue, but I would also say that the issue at hand was brought to the author, and the author politely tried to resolve that issue. Let me just make this very clear. I am supportive of the bill in its original form, which deals with the patient. And to me, that's the absolute most important issue. If you want to make this a 2-year bill, then I propose that you get another vehicle, start it all over next year, and have this conversation in another vehicle. I think the consumer issue portion is way too important, and we're injecting this conversation into an issue that maybe we're trying to mix the two. So, Senator Nguyen?
You piqued my interest. What's the difference between this and the New York bill? I mean,
there was legislation passed and enacted this year in the state of New York, which referenced an interim payment that is at this 80th percentile of this Fair Health database, which is that transparent database that we talked about. On the back end of that is a IDRP process that we also propose to the author and the other stakeholders that is binding and mandatory, baseball arbitration style. The arbiter would be either pick what the plan paid or what the physician charged. Either side could decide to enter into that IDRP process if either party disagreed with whatever that interim rate is. The way this bill is constructed, and we would envision the way in which both departments would structure their IDRP process, would basically put the onus on the physician. The physician would really be the only one who would object to those rates. So when we proposed that sort of solution, which was hailed by consumers and all sorts of people in the state of New York, is being implemented without any problem, that was summarily rejected by the author and the sponsors and some of the other stakeholders.
can I ask the author, Mr. Chairman?
Yes.
Chairman Bonta, can you just respond to that? Is that why was this completely rejected? Is this a really bad idea? I mean, it's working in New York. Is there I just want to hear your thoughts.
So thank you for your question. We've looked at lots of different possibilities. I think everything's been on the table at different times. Trying to find coalescing around a common path forward has been the difficulty. The specialists have their concerns, their preferred path. The plans have theirs. Some of the different other provider groups have different approaches. So it's been difficult. And this is a bill where we've put in hours and hours and hours more time than your average garden variety bill. And it requires it, and it deserves it. And we're going to continue to engage in the stakeholder process. But on the specific question about New York, there's a very redeeming quality to what's being done in New York, and that is relying on a public database. I agree that's important. I wish we had that here. For payments, that's a database based on charges, and that's a big problem for getting the stakeholder group together. So charges are off the table for some of the key stakeholders. If we had a public, transparent database for payments, which we don't, but we probably should, I think we would have a greater likelihood of coalescing around that approach.
Well, I know somebody who's been running that bill for several years.
Can I join as a co-author?
But somehow it doesn't get out of appropriations. So would maybe the proponents like to respond to any of the comments?
New York is obviously, as we learn, a rather different system. 80% of Fair Health is 80% of charges, which is sticker price. We have no information on what the disparity is between sticker price and prices paid for physician rates in California. We do know that for hospitals, the difference between charges and what is paid by commercial plans is a factor of 5. That is, charges are 5 to 7 to 8 times as high as the prices paid. So because we are our interest is getting the consumer out of the middle, but we also care, as this committee knows, on behalf of Health Access, about healthcare costs in California. Finding a fair balance on this is the challenge. We have spent everyone has spent an enormous number of hours having conversations. Various, as Mr. Bonta said, various options have been considered, and average contracted rate is something higher than I ever thought I would see the plan support in a bill like this. And so we are here before you today with average contracted rate and with an appeal process from that. That's what the independent dispute resolution process is. It's a non-judicial appeal process. So for all of these physicians who face the reality that they think they should be paid $500 and the plan pays $300, or they think they should be paid $1,200 and the plan pays $1,000. A difference of a couple $100 is very hard to manage in a litigation environment. So we were willing to support some sort of way to resolve those kinds of practical problems. And that's the bill before you today. And so, thank you.
I believe Senator Pan and then Senator Roth.
Thank you. A couple of questions first. First of all, I just want to clarify, this bill is not about emergency care where a patient doesn't have a choice. I mean, let's talk about, at least they're able to make decisions before they, obviously they need the medical care, but so before they go to the surgery, there's an ability to say, okay, who's going to do my surgery, who's doing my anesthesia, who's doing whatever, right? I just want to clarify that. This is not an emergency situation, patient's unconscious, trauma, and they're, right, correct?
You are 100% correct.
Okay.
Emergency care and services are explicitly exempted.
Okay, so first of all, I think these are situations where when we talk about surprise bills, it's a surprise not because they weren't able to make the decision, but a surprise because they may not have recognized, et cetera, something's coming in. And I do think that perhaps greater disclosure and trying to figure out what's the requirements for disclosure so that you have a better sense now. To understand anticipating radiology, pathology, et cetera. Clearly, I agree with and the efforts that people have made, including our chair, to create a database that we can actually see more in terms of charges and payment. But I guess I also have a concern about the sort of the average rate, because what happens is we're not talking. We have a situation where a physician has a contract with a plan. That's set. They've negotiated. They've worked out. Okay. Now what happens is you have a situation where you have a physician who probably has rejected, or there has been no negotiation between the physician and the plan, right? And now they've provided the service to the patient. And I agree, we want to try to keep the patients out. I think we also have a situation that when you say it's the average charge of all the people they negotiated with, well, you create a situation where, okay, fine, I'll negotiate with the people who take the lowest rates. And of course, they will take a low rate perhaps for volume. They could take a low rate for lots of different reasons. And then they're going to impose that rate on the other physicians who haven't agreed to that. I think that does, and it's the average. So it's not even, so there's going to be half of the people who actually got contracted rates higher. I think that gets to be a bit problematic. There's a reason why you didn't take that contract, okay? Whether for a variety of different things. So I'm not sure that is really reflective of a fair charge when you talk about fair, right? And some of it, and there could be certain circumstances at this physician or physician group's end that's different than the ones who all signed the contract, right? So what happens is I can go around as a health plan and sign contracts with a couple of groups, and that's going to be very favorable for them because of certain circumstances of volume, but then now be able to impose that rate on everybody else who don't have those advantages and isn't going to work out with their practice model. And what I'm concerned then is that what happens is that physicians can say, okay, well, I'm just not going to take a PPO of an out-of-network. I just won't see the patient. I'm not going to see you or whatever. And that's going to create more access problems because people, for example, sign up for PPOs, and I understand this is the main target, so they can go out of network. So I do have concerns about the bill. I appreciate you're trying to, this is a very tough nut to crack because, and there's been a lot of us who've tried to go around. So I appreciate what you're trying to do. I do think, sounds like it needs a bit, and you've done a lot of work, and I appreciate what the our chair and the staff has done as well. But I think there's still quite a bit of work to do, and I still see a lot of issues that I'd find problematic from even the patient, I mean, from the patient's perspective, even in terms of being sure that they get they're able to get access to the services that they need, and not creating a situation where you're going to discourage physicians from taking certain groups of patients because they're going to find that they're basically rules are imposed on them instead of them agreeing to the services that are being provided.
Thank you, Mr. Chair. I just curious about the point of this in-network versus out-of-network. So if I go to my family practice doc and in-network, and he or she refers me to, because I need some surgery that requires hospitalization, and I'm referred to an in-network surgeon who presumably, if he or she needs an assistant, secures an in-network assistant, and I go to the hospital for my surgery, from an anesthesiologist standpoint, do I have an opportunity to learn before I'm on the table that my anesthesiologist is out of network or in network, and when does that occur, and how does this problem occur?
Well, it's a little complicated, but typically what happens if you're having a procedure that's going to be requiring, general anesthesia, depending upon the case, not only will you have met preoperatively with your orthopedic surgeon, that could be a week before, a couple weeks before, depending upon what it is. You're also, depending upon the case, going to have a preoperative meeting with your anesthesiologist. They're going to talk about the risks. They're going to go through all of that. They will probably know at that point, since it is an elective scheduled procedure, whether or not they are in network or not in network.
The patient or the anesthesiologist?
The anesthesiologist will.
Okay.
So oftentimes, if we're talking about, just yesterday there was a discussion around maybe a front-end solution. Maybe there's something we can do around this disclosure piece that the provider discloses to the patient, I'm not in network. If you really want to go to an in-network provider, contact your insurer. However, if you want to see me, I'm not in network with HealthNet, and this is how much.
But that should be required, shouldn't it? I mean, wouldn't I necessarily assume that if I'm dealing with my in-network family practice doc and I get referred to my in-network surgeon, at some point I'm going to ask, or my family practitioner is going to tell me, wouldn't I assume that when I'm referred to the person that's going to gas me, that person is also in network? And if you're not, shouldn't you be required to raise your hand and say, I know you were sent in the door here, but you ought to know that I'm not in the plan and that my rate is X as opposed to Y?
I think that happens in the marketplace, and if that is something that we would want to codify, we can have a discussion about that, certainly.
I mean, it certainly gives rise to the problem, doesn't it? Where you're the patient, you assume you were going to have a $20 copay, and instead you have a $20,000 copay, or more likely $2,000, which for some people is pretty significant. Anyway, that was my question. You answered it, and I appreciate it. Yes?
I was just going to say, on behalf of the orthopedic surgeons, very, very rarely would you have a surprise bill because, as you point out, before you go into surgery, you're going to have a meeting with the surgeon, and you're going to find out right then and there that the surgeon's out of network. It really is more of a hospital-based problem, but the reason that we have an issue with the bill, at least what I think the bill is, I don't know exactly what's in the current version, is that it may cause an access problem for the anesthesiologists that we work with. We want to make sure that they're there for the surgeons.
Well, thank you very much. Mr. Chair, just one other comment here. I'm going to obviously be supportive to move this along for further work, I assume, but I have to say that I draw a distinction between allowing departments, whether it's the Department of Managed Health Care or the Department of Insurance, to implement a plan from letting those departments design the plan, as I read the mock-up. And it looks to me like they're going to be designing whatever the plan is that's implemented here, and I'm not sure that's very good government, but I'll be voting to support the bill. Thanks.
Would the proponents like to respond at all to some of the comments that were made?
Beth Cal Health Access. With respect to the Department of Managed Healthcare spent about 5 years designing a voluntary independent dispute resolution process that is not currently used because it's voluntary. So they have gone through the process of thinking it through. The bill does not require them to use that, but they have one to hand. What the bill does do, which a department cannot do on its own, is to make participation mandatory for both parties and to make the decision binding, something the department also cannot, no agency can do on its own. So there were many objections, as you may have heard, to the prior version, the in-print version of the bill. And so in an effort to address those concerns and simplify the measure, you have the language that is before you today.
Thank you. Any other comments? A couple comments. First, a question. So from its original version, at whose request was it to bring in the IDRP or this particular process? Was it initiated by your office, or who initiated that conversation?
As you know, the fundamental component of this bill is the consumer protection component. But it invites, I guess, an unwanted component that needs to be addressed. And so I wanted to have a full solution, and I invited input on what that might look like. And from that input came the idea of the IDRP.
Okay.
We're also looking at some other solutions, including a front-end solution that Senator Roth has showed and Dr. Pan has touched on. There's some potential there. And so I want to have a complete solution here if we can. As you can see, it's difficult, but I'm committed to it, and we'll continue to work on it.
Thank you. So I see this as two separate issues. I know that they could be linked, but where I'm leaning right now is that of the consumer. So let's take pre-Affordable Care Act, where an individual would purchase health insurance that they choose to, compared to post-affordable, where you're now required to purchase health insurance. Everyone has to have health insurance, whether it's subsidy, Medi-Cal, et cetera. Putting aside emergency, that's a totally different situation, because if you're brought into an ambulance, you have no control. You're going to end up there and you're going to be seen by somebody. But if it is an elective procedure, a consumer purchases health insurance, they pick the orthopedic surgeon, they pick whatever surgeon, and they go to a hospital or a facility. They, in their mind, I think, feel that everybody that's going to take care of them is in their network. And I don't think we should be putting the onus on the patient to figure out every single provider. If anything, and I hate to say this, maybe we should put the onus on the provider before they provide that service to notify the patient that they're not in network, and then they can choose to and then look for another provider. So I am looking at it from that perspective, and I think it's extremely important that part of it gets addressed, because we need to take the consumer out of the middle. Now, I understand when it comes to balanced billing, that has been around, and that has been a thorny issue for decades, and it's a very difficult one to issue, and I applaud you for trying to address it, and you may or may not address it before this legislation in this time. But I think that it's too important to not move forward with at least a consumer protection portion. If there's no resolution, I would recommend, instead of a 2-year bill, start another bill and have all parties continue this conversation next year in a different vehicle, but at least separate those particular issues, especially when you're dealing with an elective procedure. But I am more than welcome. We have a motion, I think, by Senator Roth. I'm very supportive of the issue. I appreciate the fact that you've taken the amendments that I've recommended. Would you like to close?
Yes. I want to thank all the stakeholders for their engagement in this process and commitment to the core fundamental component of this bill, which is to protect the patient, as you have so eloquently outlined. I know there's some concerns about the bill, and if this were easy, it'd be solved by now. So we're going to continue to work on it. I'm committed to that, and want to move forward and get to a place where as many stakeholders as possible can live with the bill. So thank you for your consideration and your input, and thank you, Mr. Chair, for helping us make it a stronger bill.
Thank you. And we have a motion by Senator Roth. This is AB 533, do pass as amended to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Nielsen. Nielsen, no. Pan. Roth. Roth, aye. Wolk. Wolk, aye.
Okay, that currently has 3.
Mitchell. Mitchell, aye.
I won't say where that came from. Came from the hallway. Mr. Chair, that currently has 4. We have some absent members, and we'll put that bill on call. Thanks.